Written everyone. Atopic dermatitis. Clinical features. Age-related cutaneous findings. AD has a broad clinical spectrum that varies depending upon the age of the patient. It is divided into infantile, childhood, adolescent, or adult stages. In these stages, patients may develop acute, subacute, and chronic eczematous lesions, all of which are instantly pruritus and excoriated. Acute lesions predominate in infantile AD and are characterized by edematous, erythematous papule and plaque that exhibit vesiculation, oozing, and serous crusting. Subacute edematous lesions display erythema, scaling, and variable crusting. Chronic lesions may typify adolescent or adult AD present as a thickened plaques with lichen finication as well as scale, rural nodule-like lesion can also develop. Berry follicular accentuation and small flat-top papular eczema are particularly common in Black or Asian patients. In any stage of AD, a generalized exfoliative erythroderma may develop in most severely affected patients. On-type of AD lesion can lead post-inflammatory hypo, or occasionally depigmentation upon resolution. Infantile AD, age less than 2 years, typically develops after the second month of life, often initially appearing as edematous papules and papulo-vesicle on the cheek, with sparing on the central face. The lesions may involve to form large black with oozing and crusting. The scalp, neck, extensor aspect of the extremity, and trunk may also be involved, usually with sparing on the diaper area. In the first month of life, the face infected. In more than 90% of patients with AD, young infants may attempt to relieve itch through rapid movement against the bedding, whereas other infants are better able to directly scratch affected area. In childhood AD, age 2 to 12 years, the lesions tend to be less exudative and often become lichenified. The classifier predilection are antecubital and popliteal fossa, flexural eczema. Other common locations include the wrist, hand, ankle, feet, neck, and eyelid. Although any area can be involved, cirrhosis typically becomes pronounced and widespread. Although adolescent AD, aged more than 12 years, often features subacute to chronic lichenified lesions and involvement of the flexural fold typically continues. However, the clinical picture may also change, although which AD frequently present with chronic hand dermatitis that has both endogenous and exogenous components, while others have primarily facial dermatitis, often with severe eyelid involvement. Patients who have suffered from continuous AD since childhood are more likely to have extensive disease but resistant to treatment. Such individuals may also have severe excoriation and chronic papular skin lesion because of habitual scratching and scrubbing. AD in the elderly, aged more than 60 years, are characterized by marked cirrhosis. More of these patients do not have lichenified flexural lesions, typically of AD in children and young adults. Regional variants of atopic dermatitis. Several regional variants of AD can occur in isolation or together with classic age-related pattern of involvement described above. The face is frequent location for site-specific manifestation. Eczema of the lips, referred to as colitis sicca, is common in AD patients, especially during the winter. It is characterized by dryness, trapping of mammalian lips, sometimes with peeling and fissuring, and may be associated with angular colitis. Patients try to moisten their lips by licking, which in turn may irritate the skin around the mouth, resulting in so-called lip licker eczema. Another common feature of childhood AD is ear eczema, presenting as erythema, scaling, and fissure under earlobe and in the retroauricular area, sometimes in association with bacterial superinfection. Eyelid eczema can represent the only manifestation of AD, especially in adults, in contrast to eyelid eczema due to other causes. It is characterized by lichenification of the periorbital skin. Head and neck dermatitis represent a variant of AD that typically occurs after puberty and primarily involves the face, scalp, and neck. Other older children and teenagers present with this form of AD. It usually persists into adulthood. Malassezia yeast, which are members of the skin microbiome in the head and neck area, may be an aggravating factor for this presentation, and systemic antifungal treatment with intraconazole and fluconazole may be of benefit. Eczema variants also occur in acrocyte. Juvenile plantar dermatosis present with glaze, erythema, scale fissuring on the bones of feet and plantar aspect of the toes in children with AD atopic eczema affect approximately 60% of adults with AD and may be the only manifestation of the condition. FLG mutations are associated with increased likelihood of hand eczema in children and adults, and frequent exposure to water and other irritants in household or occupational setting represent another risk factor. Atopic hand eczema typically involves the volar crease and dorsum of the hand. The palm and side of the finger may develop the deep-seated vesicle of this heterotic eczema. The rural form of AD favors the extensor aspect of the extremities and is characterized by firm, dome-shaped papule, nodal, and central scale crust similar to rural nodularis lesion in non-atopic patients. Nonmular discoid lesions also tend to develop on the extremities in children and adults with AD. Appearing as coil-shaped, aximated black, usually 1 to 3 cm in diameter, and often prominent oozing and crusting. They are similar in appearance to nummular dermatitis, occurring outside setting of atopy. Fictional lichenoid eruption, hyaridescent for atopic children, and present as multiple small, flat-top pink to skin-colored papules on the elbows and less often knee and dorsal hand. Lastly, chronic nipple eczema can develop in children and adults with AD. Associated cutaneous features. Pruritus. Intense pruritus is a hallmark of AD. The itch is often worse in evening and may be exacerbated by exogenous factors such as sweating or wound clothing. Rubbing and scratching in response to pruritus can initiate flares or exacerbate existing dermatitis, explaining why AD is known as the itch that rushes. Excoriation, lining open tear are frequently present, providing evidence of scratching. With repeated rubbing and scratching, the skin becomes thickened and leathery, with exaggerated skin marking referred to as lichenification. Atopic stigmata, physical findings other than dermatitis that are frequently observed in patients with AD. Pityriasis alba. Pityriasis alba it frequently affects children and adolescents with AD, which is characterized by multiple, ill-defined, hypopigmented macules and patches, usually 1.5 to 2 cm in diameter, with fine scaling. The lesions are typically located in the face, especially the cheek, but occasionally appear on the shoulder and arm. Pityriasis alba is most obvious in individuals with darkly pigmented skin and following sun exposure. It is thought to result from a low-grade eczema dermatitis that disrupts the transfer of melanosome from melanocyte to keratinocyte. Similar hypopigmented lesions can appear upon resolution of more overtly inflamed erythematous lesions of AD. The differential diagnosis of pityriasis alba also includes post-inflammatory hypopigmentation secondary to other dermatosis, such as seborrheic dermatitis or pityriasis lichenoidonica. Tinea versicolor is typically more subtly demarcated, with small lesions that may coalesce centrally in informed area, and vitiligo is also subtly demarcated and depigmented rather than hypopigmented. Hypopigmented mycosis fungi may occasionally present a diagnosis consideration if there is extrafacial involvement. Regular use of sunscreen and other forms of photo protection may minimize the appearance of pityriasis alba. Infectious complications. Bacterial and viral infection represent the most common complication of AD. Considering that Staph aureus colonize the skin of the vast majority of patients with AD, it is not surprising that impaired urination, which can also be caused by Streptococcus pyogenes, occurs frequently. Bacterial infection may exacerbate AD by stimulating the inflammatory cascade via Staph aureus exotoxins that act as superantigens. Eczema herpeticum represents rapid dissemination of herpes-simplex viral infection over eczemated skin of AD patients. It initially develops as an eruption of vesicle, but affected individuals more often present with numerous monomorphic punch-out erosion with hemorrhagic crusting. Eczema herpeticum is frequently widespread and may occur at any site, with a predilection for the head, neck, and trunk. It is often associated with fever, malaise, and lymphoadenopathy, and complications may include superinfection with Staph aureus or Staphylococcus pyogenes, as well as herpetic keratoconjunctivitis and meningoencephalitis. Patients with mutation in the filaggin gene and those who have both severe AD and asthma have an increased risk for eczema herpeticum and increased production for antimicrobial peptide may have a pathogenic role. Patients with AD are also predisposed to the development of widespread molluscum contagiosum. Impact on quality of life. AD has a profound and multifaceted adverse impact on the quality of life of affected children and adults as well as their families and caregivers. Instant pruritus and stigmatization often result in sleep disturbance, psychological distress, social isolation, disrupted family dynamic, and impaired functioning at school or work. Children with AD experience greater impairment in their quality of life than those with diabetes mellitus or epilepsy, and detrimental effects on productivity have also been documented in adults. Associated extracutaneous disorders, ocular manifestation. In addition to allergic rhinoconjunctivitis, the spectrum of atopic eye disease includes the chronic manifestations such as atopic keratoconjunctivitis, which typically affects adults, and vernal keratoconjunctivitis that favor children living in warm climates. Symptoms include ocular itching, burning, tearing, and mucus discharge, often in association with conjunctival infection, and blepharitis, manifesting as swelling and scaling of the eyelids Venous keratoconjunctivitis feature large cobblestone-like papillae on the upper palpebral conjunctiva, and atopic keratoconjunctivitis is more prone to scarring. Additional infrequent ocular complications of AD include keratoconus or subcapsular cataract, with anterior cataract more specifically related to AD and posterior cataract occurring more commonly. Rarely there is retinal detachment. Psychiatric disease and psychosocial burden. AD is associated with an increased risk of depression, anxiety, suicidal ideation, sleep disorder, and children attention deficit hyperactivity disorder. Sleep deprivation, pruritus, visible disease, stress, and low self-esteem contribute to the psychosocial burden of AD. Cardiovascular complication. A recent meta-analysis of cohort study found that AD is associated with an increased risk of cardiovascular complications such as angina and myocardial infarction, cerebrovascular accident, and heart failure during adulthood.